We have Sachin. Sachin is our urology interventionist from Southampton, and he's got prostatic artery embolization. And he's the person who's going to steal all our BPH techniques towards the intervention radiologist. Welcome, Sachin.
Thank you, Nanda. And thank you very much to the iTrue group for inviting me to talk to you as a non-urologist on prostate artery embolization. And I can assure you I'm not going to be stealing your patients. These are my disclosures. So we're going to have a brief overview of the evidence for PAE, some of the workup, patient selection, the treatment pathway, and I'll show you a bit about the PAE procedure itself. So we've moved on now from PAE being the new kid on the block with no evidence. We've now got some good evidence, level 1 evidence for prostate artery embolization. Multiple studies, over 400 peer-reviewed articles, 5 randomized controlled trials, data from a mid and long-term follow-up in over 1,000 patients. We've got randomized controlled trials versus some of the other techniques mentioned today and that we're going to talk about today, and randomized controlled trials against sham procedures. And essentially, the evidence tells us that in early, mid, and long-term follow-up of PAE, the following are significantly improved: IPSS, quality of life, prostate volume, post-void residual, and Qmax. PSA is reduced or remains stable. There's a high safety profile with a low rate of complications, no significant erectile disorder or urinary incontinence, and it's a good alternative to medications and surgery, especially in the elderly with comorbidities. We've got consensus from interventional radiology societies around the world, and we've also got some guidance now. So we've got NICE guidance in the UK, which, importantly says that this procedure is a technical procedure, should be performed by an interventional radiologist who's got experience in and training in prostate artery embolization. And key 1.2, patient selection should be done by a urologist and an interventional radiologist. And that's very much how we work in Southampton. It's also come onto the European guidelines, and where they have got some recommendations for prostate artery embolization, although the evidence is weaker compared to some of the other missed treatments. We still have no recommendations on the American guidelines. So in terms of a prostate artery workup, a typically initial urology workup, as we've discussed, with the basic things. At Southampton, all of our patients do have urodynamics prior to prostate artery embolization to confirm bladder outflow obstruction. However, this is not done in all centres in the UK. Anecdotally, we've found that those patients who have high Abrahams-Griffith scores on the urodynamics is a good predictor of IPSS reduction following prostate artery embolization. So we're generally referred patients with an IPSS of 8 or greater. In terms of assessment, as you know, BPO or BPH is just one cause of LUTS, of which there are many, and the urologist is best placed to make the initial assessment and then refer as appropriate. In terms of radiology workup, all our patients undergo a CT angiography, which is essential prior to PAE. In our experience, it reduces significant operator time and patient dose during the procedure, and it allows detection of the prostate arteries and potential anastomoses, which is one of the cautions when performing prostate artery embolization. It also allows us to exclude unsuitable patients with heavily calcified or occluded arteries, small glands, and if we can't see the prostate arteries on the CT, it's unlikely that we're going to be able to get into them angiographically. We've looked at this at Southampton. We looked at 120 patients at 240 hemiprostates. So CTA very successful at detecting the prostate artery origin, of which there can be many, and very specific in detecting the presence of anastomosis, which is key to avoid non-target embolization during the procedure. This is an example of a CTA, so we've got very dense contrast in the aorta here, and what we want to see is a nice hypervascular prostate. I'll just take you back here with prostate arteries entering both sides. What we do is we follow the prostate, we find the prostate artery going into the prostate, and then we trace it back to find its origin. So which patients are best suited for prostate artery embolization? There's a lot of research that's gone on into this, and we want to select the best patients because we want to have the best outcomes. So generally, patients with higher total prostate volume and higher central gland volumes are associated with better outcomes. And our ROPE data from the UK correlates with other studies that larger prostates greater than 80cc have favorable outcomes compared to smaller glands. In terms of the zonal volume, so patients with a greater central zone volume, greater than 45%, have better outcomes following prostate artery embolization. In terms of composition and histology, these are some MRI images following prostate artery embolization on the left, and this is after on the right, and you can see here devascularization of these large adenomatous nodules in the prostate. And that corresponds with a better result. So adenomatous dominant BPH is a positive predictor for IPSS improvement at 12 months and continued to 24 months. In terms of median lobe, so there's some conflicting evidence. So some evidence that the intraprostatic protrusion can be reduced following PAE. However, in our experience and general consensus is that enlarged median lobe can result in a poorer outcome and may require resection post-PAE. And we've had some patients that have had PAE and they've gone on to have a limited median lobe resection. And this is especially the case when the median lobe hypertrophy is greater than the lateral lobe and if there is asymmetrical hypertrophy. There's a concern that the patients get a sort of ball valve type of obstruction with altering of the prostatic urethral angle with the alteration in the funneling of the urine. Which symptoms benefit best from PAE? So generally, we found that the storage symptoms are the most severe symptom in our group, and PAE was most consistent when improving storage symptoms compared to the voiding symptoms, but it does improve all the symptoms across the IPSS spectrum. Other factors we've looked at, so this is from the ROPE cohort. We've looked at all these data and done a multivariate analysis on other factors such as hypertension, diabetes, and coronary artery disease, and we found that patients without these comorbidities had the greatest improvement in IPSS. Why is this? Probably because small vessel disease prevents particles from reaching distally. Also, small vessel disease may cause a stromal pattern rather than the adenomatous pattern of BPH. And calcified atheromatous vessels are not good for us and limit our technical success in these patients. So who is your ideal PAE candidate? It's someone that's informed, i.e. someone less than 70, someone that's failed medication and wants to stop them or has side effects, IPSS greater than 8. We don't want marked arteriopaths. We want reasonably healthy pelvic vessels to give us the best chance of getting into them. We want proven bladder for obstruction with strong detrusor function. We want large prostates, greater than 80 better, but at least greater than 50. We want patients who are sexually active and want to remain so. No significant median lobe, no bladder stones, which we tend to remove prior to PAE, and prostate cancer excluded using the PSA. Ideally, adenomatous dominant BPH with a high central gland volume. And who's a poor candidate, which is really the opposite to all of those. We want to make sure that we're selecting the best patients. So what are the controversies with PAE? Some may say, what's the long-term evidence? Well, we've got some long-term evidence now. There's increasing evidence for good long-term outcomes. We've got evidence suggesting 80% clinical success rate at 1 year with a 2% recurrence after that. And in our patient cohort, up to 78% of patients continue to have a response. And we've got a 23% recurrence rate at a median of 72-month follow-up. So there is long-term data out there. In terms of radiation, I often get asked about this. So when we first started out in the UK, there's a definite learning curve for this procedure. The more you do, the better you get, better your radiation doses are for yourself and for your patients. But overall, in the UK ROPE, which was the first study where patients where doctors were performing prostate artery embolization, the additional risk was less than 1% in lifetime cancer risk. So that's quite low. But there is significant intraoperative variability, and this should be performed in high volume centers. In terms of the sexual side effects, very good. There was some dry ejaculate reported in the UK ROPE and the Swiss randomized controlled trial, but this mainly was due to pre-existing medications. In our current practice and in the most of the literature, there's no effect on sexual function or ejaculation. So this is a nice algorithm that I've seen in the BGUI, which separates patients who are fit for surgery, who are indicated for invasive treatment, fit for surgery, either on anticoagulation or unfit for surgery, and it gives us a nice differentiation of the treatments available. So how do we do this in the UK? Patients generally seen by urologists, referred for a CT. and have a radiology appointment with us ourselves. We perform the PAE and the follow-up is combined. It's a day case procedure, no need for a catheter, 1 to 2 hours in the room, depending on how easy it is or difficult it is to get into the arteries. 4 to 6 hours recovery, patients go home the same day, very low side effect profile. Planning is very important. We want to make sure that we've drawn these diagrams before so we know exactly where the prostate arteries come off from using our CT to give us the best chance of success. So this is nice pictures here where we can identify where the prostate arteries are coming off. We generally use femoral access, but there is a new vogue towards radial access, although we're limited by the length of the equipment that we have to go from the wrist. Various catheters and microcatheters to allow us to catheterize the prostate arteries, small micro wires. This is an example where we use various angles to open up the prostate arteries and the internal iliac arteries. And we use various shaped catheters and wires to get into these prostate arteries. Once we're in the arteries, we tend to do AP and lateral projections to confirm that we are supplying the prostate. We do something called a rotational CT or a dyna CT. So before I come on to that, we often see sometimes collateral, so collateral here going to join the pudendal artery, and we can protectively coil these blood vessels to enable us to perform safe embolization. One of the things we commonly do for every patient is a cone beam CT, which is so once we're in the prostate artery with our microcatheter, the machine spins around and we inject contrast at a relatively low rate, and this allows us to see that we've opacified the prostate correctly and that there's going to be no non-target embolization. So you can see here nice opacification of the hemiprostate and then no contrast anywhere else. So it gives us more confidence to embolize safely, and you can get good correlation between the angiographic images and cone beam CTs. In terms of embolization, how do we do it? We can't just put coils in the artery. We need to put particles in which are going to cause necrosis of these nodules in the prostate. The particles are not small enough to damage the urethra, but they need to be small enough. Usually 100 to 300 micron is what the current vogue is for use around the world. And this is what it looks like afterwards. So once we've embolized the artery, we see the contrast going in, but it's not going any further into the prostate. So the summary is we've got level 1 evidence now. It's approved by certain societies around the world, so NICE and the European Urological Society. The controversies have been addressed, and PAE adds to the therapeutic armamentarium in the management of LUTS, which is an increasing problem worldwide. Patient selection is key, as is collaboration with urology. I don't think this is something which interventional radiologists should be doing independently. The best patients are those with a gland greater than 80 cc and who want to preserve their sexual function. And I think a one-stop approach to BPH where urologists can offer all the available things on the menu is best for the patients. Thank you very much once again for inviting me.
Thank you, Sachin. That was a very good presentation. In fact, from the urologist point of view, we are so happy to see those images, which gives us an idea. You have proved that prostatic artery embolization has a place for future, and there is a place for collaboration. Thank you very much.